Dr. Satchit Balsari here today, who is a faculty member at the Harvard School of Public Health and an affiliate at the Harvard Humanitarian Initiative, and is also works at the Cornell Hospital in New York. He's going to talk today about his experience using mobile health at the Nashik Kumbh this summer. And just a reminder for everyone who's watching online, you can submit your questions to us on social media, so please go to our Facebook page, which is facebook.com/HarvardSAI, and as well as our Twitter page, which is HarvardSAI, to submit your questions, and we'll take questions at the end. So I'll turn it over to Dr. Balsari.
Good evening, everyone. We will get started. Apologize for the delay. Building off the themes that have been covered so far this semester, this webinar will focus on mobile health at the world's largest gatherings. We will talk about some of the work that Sai did at the Nashik Kumbh, but the story begins a couple of years before that in Allahabad, and it is important for us to explore some of what we had done then to understand why the Nashik experiment was a success. The Kumbh Mela, as some of you know, is one of the world's largest gatherings. It happens once every 12 years in 4 different cities in India, and I will certainly explore the history of the Kumbh Mela with you. The Mahakumbh Mela, which occurs once every 12 years in Allahabad, is the largest of the Kumbh Melas. The last one was in 2013, and Harvard University was at that Kumbh Mela in large numbers. If you look at this graph and see some of the large mass gatherings around the world, you will see that the Kumbh Mela by far outstrips the rest. 80 to 100 million people showed up at the Allahabad Kumbh Mela. In order to understand why they show up there, we have to visit a little bit of Hindu mythology. So the gods and the demons were churning the ocean in search of this kumbh, or this pot of nectar, or amrit. And in this battle, the demons got the amrit for a short time, and the gods gave them chase. And they chased the demons for 12 cosmic days, which equal to 12 cosmic years. And during that chase, 4 drops fell in 4 cities in India, one of which is Allahabad. Hindus believe that 12 cosmic days are equal to 12 human years, and so in commemoration of that great fight, the Kumbh Mela is celebrated once every 12 years at these sites. The question, of course, to me is, where are you going to fit 100 million people in India? There really isn't much extra space available in our backyard. And the answer is here. You're looking at it. This is the riverbank, the sandbanks of the Ganga and the Yamuna. So the white part that you see is where the water has receded after the monsoons and exposes about 50 square kilometers of the riverbank. On this bank, you will see this massive undertaking. So an entire temporary city is built on this exposed sandbank. You are looking at several kilometers of roads, hundreds of thousands of tents for pilgrims that will visit it, 19 bridges, hospitals, entire infrastructure. And this is what it begins to look like. This is a few months. Once the river has receded and the sandbanks have been identified, you see people coming on. Very soon, the temporary shelters go up, and they expand very rapidly to look like this, where it stretches from horizon to horizon. Day and night, there is a lot of activity going on, and this site is called the Kumbh Nagari, or the Kumbh city or township, which essentially extends far beyond the boundaries of the riverbanks. What you now see is the Kumbh Nagari divided into 14 administrative districts. The way this works is, for a transient amount of time, the entire administration of this township is taken out from the purview of the local administration, and an independent administration is set up here. So they have their own infrastructure, their police, their fire, their paramedics, their electricity. And this is a layout that essentially gets set up for the people of India to visit. As you see, people come from all walks of life. There are, of course, many holy men that will come, but there are women and children. And on the busiest days, the crowds begin to look like this. This photograph is taken on the busiest bathing day called Mauni Amavasya, when 30 million people, 30 million people showed up on one day to bathe in the Ganges. A closer look at this will give us a sense of what the crowds look like. You see that it is densely packed. There are barricades. By and large, people are in extraordinarily close proximity, even by Indian standards. If you zoom in, you will see that that's how tightly packed the people are. Of course, the risk of stampedes is high, as it is in mass gatherings. What they're all trying to do is to get onto one of these 19 bridges to get to the other side, which is called the landing or the staging area, which can get pretty crowded. This is where people will wait their turn to get into the water. This is a photograph, an aerial view of what the staging area looked like on the busiest bathing day, when 30 million people gathered on the water's edge. You can look at the density, especially if you look very close to the water's edge, you will see the millions that have gathered there. The bathing ritual goes on day and night. The whole point of the Mela is that people believe, Hindus believe, that it is purifying to bathe in the Ganga, that they will rid themselves from the cycle of rebirth if they are able to, on auspicious days, bathe at the confluence of the Ganga and the Yamuna, or at the Sangam. So this was the mythology and the social aspect of the Kumbh Mela. It was important for us to study that because as epidemiologists, when we look at this, and I see hundreds and thousands of people gathered together in such close proximity, we cannot but help think of the trillions of germs that they bring with them. And as they bathe in the water and they drink this water, the potential for epidemics, waterborne diseases, foodborne diseases, there are communal meals there every so often, is extraordinarily high. The government does many things to prepare against these epidemics, one of which is the preparation for the quality of the water. The Ganga, as you know, is very polluted. There is a lot of sewage affluent in the Ganga upstream. Several weeks before the Kumbh Mela, the government will shut off the sewage affluent pouring into the Ganga. The timing at which they shut off the affluent is very interesting. They will calculate how many days it takes for the chemical or the sewage affluent, once dumped into the water, to actually reach the bathing sites. And they will factor those days in to turn off the affluents at multiple sites upstream. They also, along with these dams, control the flow of water such that the water is just brisk enough to keep washing any new human affluent away, yet slow enough to not risk drowning at the river's edge where people have gathered to bathe. Over 30,000 toilets are constructed. They're of all sorts. And to factor in open defecation, they have an army of 9,000 night soil sweepers that will pick up the feces and dust them with line. Water is divided into grey water and clean water. It is recirculated. The grey water is used to tamp down the sand that flies from the rivers. And you will see that there is all kinds of provision of water, and some will and will not use the purified water available. So you have to factor in a lot of the public health habits as we explore understanding what the disease process and the outbreaks might be. If you look at this photograph carefully, on the right-hand side at the bottom, it says, "Ye pani pina yogya nahi." And we said, aha, Public Health 101, the woman is probably not literate, and she is drinking that water. So we went up to her and said, don't drink this water. Can you read the sign? And she said, of course I can read the sign. So, well, it says, don't drink this water. And she said, oh, I'm not going to drink it. I just want to gargle my mouth with it. And so best laid public health plans have to factor in social mores. This was a brilliant private public health intervention. Lifebuoy soap branded their rotis with this message. It said, Lifebuoy se hath dhoya kya? Have you washed your hands with Lifebuoy soap? Just brilliant, simple 1 million rotis with a message every time someone went to reach for bread, it reminded them to wash their hands. We conducted several studies looking at E. coli counts, upstream, downstream, and actually found them to be a lot lower than we expected. But the reason we're here today talking about all of this is to understand mobile health and mass gatherings. One of the things that the government had to provide for the millions that visited it was healthcare. And healthcare was at the Allahabad Kumbh Mela, set up through 14 clinics at different sites along the 14 districts of the Kumbh Mela. People lined up in a queue. Privacy concerns are a little bit different in India, so everyone wanted to know, Ram bhaiya ka kya hua? So the whole village shows up. And the number of people that the doctor sees per shift is extraordinarily high. There were some shifts on busy bathing days where each doctor in an 8-hour shift would see hundreds of patients. So there was very little time for the doctor-patient interaction. They barely had time to scribble the name and the chief complaint. And essentially the chief complaint became the diagnosis. There wasn't much time to document, write, or intervene much more beyond that. We were trying to see how we could set up a surveillance system, these hundreds of thousands of people showing up, millions on certain days. If there was a disease outbreak at one of these 14 sites, how would we even be able to capture this data? Step one was to be able to read what was written in these registers. And so we sat around and we pondered and we said, we're Harvard University, we have to make some intervention. What is the first intervention that we can do? We're here to study this project. How can we support the local teams? And the first brilliant intervention was vertical lines. We drew lines on the register and made it extremely legible. Though the information captured here was very rudimentary, it is sufficient from a syndromic surveillance perspective. All we needed to know is what people were coming into these clinics with over time. So at any given point in time, I wanted to know, was there a rise in fever, or fever and cough, or a certain kind of rash across the 14 clinics in real time, simultaneously, day in and day out? You wanted to be able to access these registers. These registers were separated by many kilometers across the Kumbh Nagri. The crowds were dense, so you could not zip back and forth on a motorbike very quickly. It would take hours to go from clinic to clinic. So the challenge is, how do you get this very rich information, right? You wanted to know if there was a spike in the presentation of certain diseases. But in order to do that, I needed simultaneous access to 14 registers constantly. We said, look, it's 2013, let's come up with a digital solution. What if we had an app on our tablet and that captured the same information that the register captured? Now, what was interesting is, as we had designed the software sitting in Boston and New York, we came up with this complex system where you picked up a syndrome and it came up with criteria to meet the diagnosis, and you would pick the diagnostic tests, and it will eventually confirm and log the diagnosis. Very quickly, after a few minutes on the ground, we realized that was not going to work. The only information that was being captured was the chief complaint, so we very quickly modified the tool. And this is very important in understanding mobile health. As physicians, we are subject to very complex EMRs, or health information systems, electronic medical records, and by and large physicians are known to dislike them. And the reason we think that is the case is because often these EMRs meet more than just the clinical demand. They are meant to serve billing interests, they're made to serve administrative interests. At the end of it, the end product is so cumbersome that it does not really facilitate either the patient-physician interaction, does not make data easily available to the patient, and does not make the provider's workflow better. What we therefore did is took a very simple tool, put it on these iPads, deployed the tablets through a voluntary army of medical students from the Rotary Club of the Caduceus in Mumbai and local public health and medical institutions in Allahabad. These medical students sat with the iPads, they sat right next to the doctors that were documenting the patient interaction in the registers and transcribing that data digitally. Every evening the iPads would be gathered, we would use mobile hotspots and essentially beam the information onto the cloud. And what you're seeing on the screen is a remote analytic frame that could be accessed from anywhere in the world that shared information about what was happening on the ground. So this is very simple information, right? Those of us that use technology understand this very well. You know, there's digital technology, you put it on the cloud, you could access it from the cloud. It's very easy to understand it in almost any other sector, but seldom in public health do we push the boundaries of these applications, largely because of these perceived barriers of user adoption. First of all, we wanted to see whether a system like this would work if the infrastructure could bear the volume of data that was coming in, because we were capturing thousands of data points a day. The short answer is yes, it worked. We piloted this system for about 15 days, and then a smaller component of the system for the entire 15 days of the Kumbh Mela. The graph that you see will show you disease trends. Our hypothesis was that with the change in the population every day, you couldn't simply rely on a spike. Diseases would go up and diseases would go down, but all they could reflect was a change in the population. Every day 1 million or 2 million would show up at the Kumbh Mela, and on the busy days, the populations would jump up to 10, 15, 20 million. So how would you know whether a spike is truly an epidemic outbreak or whether it is a mere reflection of the population change? And what we said is, if we are able to follow these diseases over time, and you see all of them rising and all of them falling simultaneously, that's probably a population change. But if there is a deviation, a higher slope in one compared to the others, that should set some alarm bells ringing. So this was, these graphs were done retrospectively. We did some more analysis and looked at prescription patterns more carefully. We saw that most people that showed up at these clinics, at these mass gatherings, and this is not different from the Hajj, this is not different from the Olympics, this is not different from the Avon breast walk. By and large, when people come to the clinics and these mass gatherings, the chief complaint is usually some kind of musculoskeletal pain. Some of them come from fever, cough, upper respiratory symptoms because it was seasonal, and then abdominal pain. We also saw that almost everyone got a treatment, a 3-day supply of medication, and the majority of them got symptomatic treatment. They got some paracetamol, they got some anti-allergics, and a lot of them got antibiotics. So that brings me to 2015, what we're really here to talk about, and which is disease surveillance at the Nashik and Trimbakeshwar Kumbh Mela, which we recently concluded in August and September. Now, what we had until this point is a pilot that we had tested in Allahabad. We said, look, the technology seems to work. Real data is available. What was different, of course, is Allahabad was concentrated into this Kumbh Nagari in the river. At Nashik and Trimbakeshwar, we had two sites. Trimbakeshwar is open, it is idyllic, it's by the foothills of the Brahmagiri hills. It's quite gorgeous. And Nashik, as you know, is a dense urban city in Maharashtra, in western India, where there was no Kumbh Nagari set up. People would be interacting with the city itself, interfacing with the people of Nashik. There are 55 clinics. We thought Nashik was going to be a smaller event than the Allahabad Kumbh Mela. A total of 20 to 30 million people were expected in Nashik. So we said, of course, we can manage this, but we were in for a pleasant surprise. We didn't have less than 14 clinics, but there were 55 clinics. There were many referral hospitals because the city infrastructure was still up, and people would interact with the existing town infrastructure. What was entirely different about the Nashik Kumbh Mela disease surveillance system, that is, we wanted it to be live. There were going to be no medical students sitting next to the doctors transcribing this data into the digital pad. We wanted physicians to be able to directly input this data into their tablets. We were looking at 100 physicians, 35 key sites closest to the bathing areas in Nashik and Trimbakeshwar. We knew that some of the barriers might be digital literacy, though we hypothesized that given that the majority of the doctors and nurses had some kind of smartphone, as long as the user interface was intuitive, we should be able to get them to use it. And as long as it made their workflow better and easier, we were confident that user adoption would not be an issue. Infrastructure was going to be a challenge, of course. Getting the tablets, Wi-Fi, bandwidth. Now, in India, especially around Nashik, there was decent both broadband connection and some Wi-Fi connectivity. What we did was decided to have a backup system. We rented tablets. We rented about 50 tablets, put SIM cards in them, so they had 2G, 3G connection, but we also had mobile hotspots, so data could be transmitted via Wi-Fi. And all our preparation was geared towards this last point that you see on the screen, user adoption. What is it that will make 100 physicians we have never met adopt this health information system in a day and age where we seem to all be convinced that doctors don't like to use EMRs? And what real use would a system like this actually be? In order to prepare the user interface, we met several months in advance. You see a part of our team there on the left in Bombay. We went to Nashik. We met with the district health secretary. We met with several of the officials. We met several local stakeholders, including the Swamis. And we met with the doctors that had come there for training. We talked to them about the program. We showed them the presentation that you just watched about the Allahabad Kumbh Mela and the rich data that is sometimes available right in front of you that you do not have access to, but that if it is available can give you such extraordinary clinically relevant information. Resource utilization. There was 14 clinics in Allahabad. Some of them saw 3 to 4 times as many patients as some of the clinics that were farther away. Yet all these clinics were staffed similarly. You found, prescription patterns that were not advisable, but you could have seen them in real time and intervened. And most importantly, we were looking for spikes in diseases, and we were able to follow those as well. How do we then actually operationalize this, mainstream this, get this into, make it institutional? We identified multiple partners. The government of Maharashtra Public Health Department under Principal Secretary Sujata Sonik was completely on board and galvanized her entire team to support this and to allow the software tablet to be incorporated into the regular workflow at 35 of these clinics. We were supported by UNICEF and Colgate and a plethora of institutions in the US and India. I want you to look at the left-hand bottom corner, and you see that we're speaking to a man in saffron robes, Swamiji. The reason we were doing this is because another component of our intervention in Nashik was going to be non-communicable disease screening. The reason for doing that is, if you remember a few slides ago, I said what the majority of people come up with is, back pain and cold and cough. And yet the government, the exchequer, mobilizes lakhs or tens of lakhs of rupees to set up this infrastructure. What we advocated for was to use this opportunity where millions of Indians are passing through the Kumbh Mela, through this healthcare infrastructure, to do non-communicable disease screening. Said, can we do hypertension screening? Can we do diabetes screening at these mass gatherings where you have exposure and an opportunity to interact with millions of people? So the other project, therefore included in Nashik, which we will not be talking about in much detail during this seminar, but I'm happy to take questions later, was non-communicable disease screening. We screened thousands of people for hypertension, for diabetes, and will now be following up with them over the next 6 months to see whether that kind of a screening program at mass gatherings was of any use. You're now looking at an extraordinarily simplified interface. This is all the patient, this is all the physician had to enter. An ID number for the patient, age. We had much debate about what the sequence of the ID number should be. We decided that anything more than 4 letters was not going to work when you had to log hundreds and thousands of patient encounters all the time. The surest way to create errors was to have, multiple digit sequence. So we came up with this written sequence where 2 letters would signify the clinic location, so one of 35 clinics, and then 4 numbers would make the patient sequence. And the reason I'm talking about this, which probably seems very uninteresting to you, is this was exactly the kind of attention that is often not paid while creating health information systems. And so every single field that you see there was debated back and forth, not only across our teams and multiple institutions in the US and India, but also with teams in India with the doctors that were going to use it. Will you write 2 letters? Will you write 1 letter? Will you write 3 digits? Will you write 4 digits? Will you write the medications? Will you not write the medications? At the end of it, we decided that for live disease surveillance, all we needed was the age, the gender, and the chief complaint or diagnosis. There was no other information that was useful either to the doctor or to the patient. And that is the only information we decided that the tablet interface would have. A month before the deployment, we met with several of the teams to have them test the tool, to give us feedback, to see every touch, every swipe, every click on the tablet and what reaction that generated, whether doctors liked that, they didn't like that, what needed to be changed. We also visited the sites to see if internet connection was going to work, and some of these sites were fairly remote. We also realized that electricity was going to be a challenge at some of these sites. The electric poles were far away. So, here you had a research team, but you had to kind of think through implementation, and this is the fun part about doing, field work in public health. So my team was pleasantly surprised when they found that one of the things we had to do was build out these extension boards for every laptop. So every clinic actually had a packet that was given to them with a charger and extension board, getting ready at these 55 sites that the team geotagged. And so this was the preparation. we had everything in place. We had a software, we had the sites geotagged, we had power cords, we had rented tablets, we had SIM cards, the tablets were labeled, we met the doctors, and finally the people arrived. The Nashik Kumbh Mela had begun, the Trimbakeshwar Kumbh Mela started next. Lots of crowds. It was not as dense as Allahabad, but it was the peak of the swine flu season, so there were lots of concerns of outbreaks, the same water bathing rituals, the same kind of crowd density in Nashik as well. Our team worked 24/7, day and night. They visited all 35 clinics every single day, every single night. You know, you're taking a new health information system, giving it to 100 doctors you have never met before and expect them to use it. Our biggest question, of course, was, is this going to work? Why would the doctors adopt it? What do they need? What is working? What is not? And it was imperative that we were in close communication with them. The project was going to, in spite of all this preparation, was going to be operationalized only on the busiest bathing days, on the day before and the day after. So there were 4 busy bathing days, and so we had a total of 12 days in which we were going to capture thousands of visits. But 12 days is a very short learning time for adopting a new health information system, using it consistently and avoiding errors. It normally takes months to roll out EMRs in large hospitals in the West, and we had about an hour. And so to compensate for that, we were available 24/7. There was a hotline set up, and the site visits occurred every morning and every night as well, because they had the day shifts and night shifts, 50 doctors during the day, 50 doctors at night. At the site visits, we retrained them. We had user feedback forms where we asked every physician that used the tablet whether they liked it, they didn't like it, whether they would use it again, what they would change about the software. And between the busy bathing days, we often had a few days interval. And in that interval, we would change the interface in real time so that by the time the doctors used it again, the changes they had asked for had been incorporated. The critical part, of course, was the analytics. Did this work? Yes, we had a bunch of tablets and we gave it to doctors and they put in some information. What's so great about that? Why a webinar about mobile health? What are we really talking about here? Did this have any impact? I'm going to pause here for a second. Not to create suspense, but to change screens and show you what the tool actually looked like. Could you, my power cord? Oh, sure, thank you. It's a large white cable. It should be in one of the 3 zippers. Yeah. Thank you. So this is what thank you. This is finally what our dashboard looked like. We had scientists from Harvard, from Cornell, from UCSF. We had administrators from the government looking at this dashboard in real time. You see that this was phase 1. We can look at the data for different phases. This is for phase 1. In real time, all the administrators and all the physicians that were using the tool were able to see the distribution of patients by age, the sites at which these patients arrived, the distribution by gender, by location. You saw distribution by disease. You saw the frequency of diseases as predicted: joint pain, right? Out of 8,000, 2,000 had joint pain, and 2,000 had cold and cough, not dissimilar to Allahabad, not dissimilar to the Olympics, and you could see the trend in time. What was particularly unique about this analytic tool is that it was interactive and that the government was able to sift through this data in real time as patients were coming in. So it was possible for the district health secretary to say, I want to know what is going on only at Nilgiri parking, and then, as you see, the entire dashboard will change to reflect only what is happening at particular sites. If you were worried, for example, about a particular outbreak, you wanted to see where most of the fever was showing up, and whether it was mostly in men or mostly in women, or you were worried about a particular age group, you wanted to know what the young and the children were mostly coming in with, or just the elderly, you could immediately get that information, quite literally and figuratively, at your fingertips. You could also look, and we thought this was incredibly useful as well, for the variation by time. So you could move the time slider and see what the difference in disease patterns was. What this allowed one to do was to respond in real time to the complaints coming in. So, for example, the government would be looking at this dashboard, the health secretary, and then they would say, look, there is a death being recorded there. Can you go investigate that death? Tell me what clinic it is at. So let me pick something that has very small incidence here. Hypothetically speaking, let's say we're worried about these chest pain patients. It says 9 diagnoses. You could immediately see where they were, what the age group of these people were, and see what time even these chest pain patients came in. You could then go to that clinic, get more information about who was staffing that clinic, call the clinic, and see if the chest pain patients were okay, if they were transferred to a hospital or not. If you visit our website, and I will share the link with you later, you will find excellent testimonies from the doctors that were using it. I'm going to try and switch to a video to show you what this looked like on the ground. So this is the distribution, the training, that's our team. That's Dr. Yadav and Dr. Desai kind of doing a site visit. They had internet connectivity issues, so now they're using their own hotspot. So this is why the daily site visits were important. You can see how remote these areas were. This is incredible, right? Just very little infrastructure. As you can see, there's, barely any electricity, barely any other infrastructure. You're out on these remote posts, and yet this very simple use of very simple technology gives you this extraordinarily incredible data. This was key. The doctors, I'm going to pause you for a second, the physicians were able to pull up the visual analytics tool, the Encounter tool, on their phones, and they could see in real time what diseases were coming in, who was seeing more patients, who was seeing less patients, what was worrisome. And this was very galvanizing. Once they had access to this data, suddenly the physicians knew why you were collecting this data. This is seldom done when we build out these health information systems. That's, you go click, 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 click all day long, and doctors don't understand why they are entering all this information that sometimes is not very useful to them or to their patients. Suddenly, when these doctors saw the impact of their data in real time, we had amazing compliance. We had physicians enter, so each of these 100 doctors entered at an average 4,000 patient encounters during the study, a total of 40,000 patient visits and 100 doctors that had less than an hour of training.
This must be busy patrolling today.
Some of the other data sets that we were able to, again, generate in real time are, of course, the government had its own needs and reporting views, so in spite of the interactive tool, one needed to also have some hard numbers to report. We were most interested in the delta, right? The rate of change. Was the rate of change of a particular disease more than the rate of change of other diseases? We were also able to look at some of this data segregated by site, so you can quickly see if there is a mismatch in resource allocation. As compared to Allahabad, in Nashik, I'm going to switch slides again here. In Nashik, we were, because it was institutionalized, because the government was able to use it, we were able to get the desired on-ground change that we were hoping to get. Meaning that as soon as we realized that there was a supply-demand mismatch, you saw that some clinics were extremely busy at certain points in the day, and some clinics were not so busy at all, and they both had the same staffing. By the time the next bathing day came around, the local administration had already switched staffing. We realized, and this is one of my favorite testimonies, and I'll show you where to find it on our website, there was a spike in diarrheal cases, and the board immediately showed that there were a lot of diarrhea cases coming in real time. By 11 o'clock in the morning, one clinic had 30 cases of diarrhea, and immediately the district health department deployed water sanitation engineers to inspect the taps to see what the problem is. And you have this joy that you see registered on the faces of the clinicians, of the providers, of the nurses, the doctors, because suddenly they're now part of the bigger public health response at the Nashik Kumbh Mela, caring for these millions of people, and they see where their little clinic fits in this larger picture. So what does all this mean? I mean, yes, it was a very cool project and we generated a data set. But what is the success of both the user adoption, the fact that physicians who one had assumed were not going to have good digital literacy and or were going to be resistant to using this, and not only use it, embraced it, liked it, asked us to use it in their own clinics, and used the tool 4,000 times in 9 days. What are the implications of these findings? And here are the three areas that we will be looking at here at our team. One is this notion of leapfrog technology. Clinics in South Asia, in India and Pakistan and Bangladesh and Nepal, mostly, by and large, do not have electronic medical records. They may or may not have fixed internet landline connections and may not have PCs. However, the majority of these clinics, even in the remote locations, have excellent phone networks and coverage. There are 980 million cell phone users only in India. India is about to roll out 4G connectivity, while the connection and the bandwidth is not as expansive in the neighboring countries. The use of telephones, certainly simple phones, but also smartphones, is quite ubiquitous. Can we therefore not then harness this technology and kind of leapfrog into the future? We don't need landlines. We may not need hundreds of millions of dollars spent on building out complex EMRs. Can we use can we essentially crowdsource this process? Can we build safe, secure platforms by which simple mobile health information, mobile health applications, mobile health technologies can be used to harness this extraordinarily rich data that can revolutionize the way we address healthcare service, healthcare delivery on the subcontinent? Imagine the kind of data that was possible, the kind of information that was possible from these data that we saw in real time. You could observe practice patterns, you could map supply to demand, you could look for epidemics, and it was all portable, and it was all mobile. So picture clinics, primary health centers across South Asia, the second-tier hospitals. Imagine the inventories, imagine disease patterns, and imagine these remote visual analytics. Suddenly you are sitting in the context of Nashik, right? You're in Nashik, you know what is happening in the villages. You're in Bombay, you can pull up these dashboards and you can see you're worried about a swine flu outbreak, and you are, the Secretary of Health. You can pull up these dashboards and see what areas are seeing huge spikes in diseases. You're an epidemiologist, you're a public health consultant to the government. You can play with this data in real time, not 2 years later, in order to write a publication in a journal that none of your patients or your administrators are going to read. Big data, data science, as these fields evolve, when they interface with mobile technology, with mobile health, suddenly make these data that were locked up in papers and publications and scientists. It takes these data and makes them available not only to health administrators, but also to the public. People can see the impact of these data. A colleague of mine, Dr. Kazi, who's a cardiologist who was on our team in Allahabad, points out that half of the people that you saw in this photograph will die of cardiovascular disease. That's profound, right? And we have the data there. We have people coming in. We can see whether they have hypertension. We can see what the intervention needs to be. We can study what the burden of disease can be. The resource supply-demand matching is one of the most attractive components to me. To be able to be in Bombay or Lahore or Islamabad or Kathmandu or Dhaka and know what the villages need, where you're running out of inventory. I see remote analytics and humanitarian response. I am referring here to a situation in Akobo, which was 4 years ago called the hungriest place on earth. It was a remote town in South Sudan where the local NGO that was doing blood transfusions, of which they had to do many because malaria was endemic in the region and the women were very anemic and they needed blood transfusions, were being done without testing for hepatitis C because they had run out of hepatitis C kits. In order to get kits, the message had to be transmitted from Akobo to the capital, Juba, from Juba to London. Papers had to be filed, requisition forms needed to be filled, and then 6 months later the kits would show up. We live in an era, in a day and time and age, where tapping a little piece of glass on the palm of our hand makes a pizza appear at our doorstep. Why then can we not be a little bit more responsive to meet the public health needs of our populations? Refugee crises don't have infrastructure. Again, using simple mobile technology like this can help us log their health and public health information while they're on the move. We're very excited about the potential for adopting on a massive scale mobile health technology in South Asia. We're now hoping to test our system at a couple of different states in India on a statewide basis. The goal is not to sit and build out EMRs at all. The goal is to figure out how we can construct secure, safe platforms that allow us to crowdsource many others like us to come and build out these very simple technologies that can provide us such extraordinary data for public health interventions. Do visit us at harvardscikumbh.com. You will find the entire process logged and blogged at this website. Our team has shared photographs. Our team has shared a lot of writings from their daily journals. And most importantly, you will see testimonies from the doctors and nurses that used the tool. Thank you very much for listening. We'll be open for questions for a few minutes now.
Great. Thank you so much for that presentation. So I have a few questions that some people submitted on social media, so I'll go with these now. But as we're talking, if you have your own, please, again, go to our Twitter or Facebook to submit your own. So I have one question here from Lisa on Facebook, and it's kind of a general question. She's curious, what was the biggest challenge you faced in both planning and implementation?
So the question is, what was the biggest challenge we faced in planning and intervention? And I know some of my team is tuned in and listening right now, and I can see them smiling. So I think our biggest asset was government cooperation. The fact that this was institutionalized, that this was mainstreamed, and that we were not a peripheral science project happening in the background. We were the way this tool, the software was adopted by the government. We were merely a support team for the government to implement this. So that was the strongest asset. But we also realized that with these public-private partnerships, that there are extraordinary challenges. They both work very differently, and at multiple points, I think, not being able to see the public sector be as responsive as one needs to be in these circumstances could be very frustrating. So, a month before implementation, when we were testing the tool, for example, we were hoping to have 10 to 15, tablets to work with the 100 doctors that had been called in to give their feedback. And, the tablets never arrived, and we essentially conducted the entire training off our 2 phones. And I think it's those little things like that in retrospect seem so trivial, especially because, the project succeeded, and, it was an incredible intervention, and we had such good feedback from all the users. I think that then and there, in the moment, the consternation that it created was just not worth it. You have a few highly skilled people with limited time that come from the private sector to engage with the public sector, or come from academia. I think we ought to figure out smoother, seamless interfaces between these various groups to avoid sometimes what amounts to colossal wastes of time. I think that was the mildly frustrating, not very. We've been on the field, often before. This was not a first rodeo, so we anticipated some of this, and the photograph of the phone chargers is a case in point. You learn to anticipate, and that's what makes a lot of this public health work so much fun.
Great, thank you. And so we have another question. This is from Twitter. It's from K.M. Gupta, who is in Delhi. He's saying that the Nashik Old City roads have huge traffic problems even in the normal days. So what about the Kumbh Mela, and how did that impact any health problems you had?
Well, Nashik and every other city in India or in South Asia, very efficiently, the government, and we saw this in Allahabad, with the bridges. If you listen to Professor Rahul Malhotra's talks on the site in Allahabad, he will explain to you, and this is definitely worth watching, so Google it if you can, that all the roads that you see on either side of the riverbank in Allahabad were connected by a bridge, so you did not break traffic. People continued to move from one side to the other, and it was very critical from a town planning perspective. Similarly, in Nashik, there was a lot of work done to control traffic that flew in and out. So this is a great question. Imagine concentric rings around Nashik and Trimbakeshwar. So 10 to 15 kilometers away from Nashik is what they call the outer circle, which had outer parking. Closer to Nashik, about a kilometer or two from Nashik, you had the inner circle with inner parking, and then finally the bathing sites. People coming from across India came from one of these four routes, and haven't covered this in the webinar, but our clinics are distributed along the lines of these various routes. What everyone was required to do was to give up their vehicles at the outer parking. You parked at outer parking. If you came by private vehicle or private bus or train, you stopped at outer parking. From outer parking, you then took state transport buses, and only those would be allowed to apply those 15 to 20 kilometers from outer parking to inner parking. And then from inner parking, you would walk, and you would walk only on designated one-way roads. Most streets were shut down around the busiest bathing days. It was almost like a little bit of a curfew around the bathing days in Nashik and Trimbakeshwar, where traffic was highly regulated, and implementation was fantastic. The police would not allow anyone, irrespective of what minister you were, or what VIP, or what senior police official, if you did not have the right credentials, you were not allowed to pass through. What is incredible about both these melas is you see the state machinery at its best. You see the UP government in Allahabad and the Maharashtra government here do an extraordinary job. For the public sector that is critiqued and criticized, and often with justification for its inability to implement. Both these events see an extraordinary amount of efficiency from all parts, from all aspects of the government. So stampede mitigation is a massive concern of both the Allahabad and the Nashik administrators, and they do a fairly good job controlling the flow of traffic in and out of these locations.
Okay, thank you. I think so. We have just a few more minutes. I see someone asking, it's just more of a comment. He's asking, what was the biggest surprise in terms of health outcomes that you found? I know you mentioned you found that the most common ailment is usually musculoskeletal. So when you were doing this, what was the biggest surprise, or was it what you expected?
I think we were less surprised about the epidemiology in Nashik than we were in Allahabad. In Allahabad, going in, we had just assumed everyone was going to have waterborne, foodborne diseases. Diarrhea was going to be the number one chief complaint. And you see that the infrastructure is also set up accordingly. You had clinics with 20 inpatient beds, largely for cholera, because cholera used to be a big concern at these Kumbh Melas. But that was not the case, and it was, musculoskeletal. So going into Nashik, we were a little bit prepared for that. Our surprise was not what we saw in the data. Our surprise was, and pleasantly so, was the user adoption. I think as much as we had, hoped that the physicians would use this, we had hoped that the government would look at the dashboards, we, I think, were completely unprepared for, 100% compliance and acceptance, and which has taken us seriously back to the drawing board to see, okay, there was something here that was done right, and what is it? We don't want to fixate on the wrong aspect of this and run with it. So we've gone back to every single physician, to the administrators, and we are through quantitative and qualitative surveys and through focus group discussions to ask them what it is that worked. All the doctors used it, with an exception here or there that took some time to adopt it. But the numbers are here for you to see, 40,000 in 9 days, day in, day out, glowing reviews on the feedback. And so it is that we were, pleasantly surprised, but frankly unprepared for. And so we are hoping that we can identify what those key ingredients of success were, so that we can scale this up. It's time to. There is really no excuse for South Asia to not be adopting mobile health, on a very, very wide scale. We are missing. There is paucity of live data across the subcontinent, and there really isn't a good excuse for that anymore.
So I don't see any other questions for now, and I think we're just about time.
Yeah, 9:30.
So perfect, right on the dot. Thank you to everyone who's watching now. I know there were quite a few watching. We will post all of this on our website, so we'll post a link to the team's blog. We'll post a recording of this session and some other resources, so we'll have that up on our website soon. So thank you to everyone who's watching, and thank you.
Thank you for your patience. Thank you for your interest, and a big shout out to the entire team. We were, a team of about 40 researchers and 100 doctors and nurses in the field, and a big thank you to everyone for making this happen. Thanks a lot.
Thank you.
Thanks, Amir.